The broadcast is now starting. All attendees are in listen-only mode.
Good evening. I am Brad Tice, the Chief Clinical Officer for PharmMD Solutions, a medication therapy management company in Brentwood, Tennessee, and current Speaker of the APhA House of Delegates. I will serve as your moderator today. For your background information, please submit your thoughts on the policy topics throughout the webinar or send them to hod@aphanet.org. If you are using a phone line to listen, please dial the number provided on the screen. To request to speak, click on the Raise Hand tab and you will be placed in the queue. There will be specific times following each policy topic and at the end of the session for audience participation. The comments we take or mention on the webinar may be limited due to time. However, all comments will be provided to the Policy Committee for use in their deliberations. The moderator will clarify issues but will not engage in debate. Remember, be courteous to your colleagues in your communications. The goals of tonight's webinar are to provide an opportunity for delegate input on policy topics prior to statement development by the Policy Committee, to promote the early engagement of delegates on the development and submission of quality new business items on topics not assigned to the Policy Committee, and to generate delegate interest in policy and House-related committees as part of the policy development process. Today's webinar has 4 objectives: to review the purpose of the House of Delegates and to discuss how association policy is used in the activities of the association, to review the policy development process and to discuss how this webinar fits into the process, to review the proposed policy topics and allow the APhA House of Delegates and membership an opportunity to provide their perspectives on the issues, and to generate interest and solicit names from the Policy Committee and other related committees. The APhA Board of Trustees, at the recommendation of the AP Academy's Joint Policy Standing Committee, has assigned the following topics to the 2011-2012 Policy Committee for Policy Development. The first topic policy area is the impact of drug supply shortages, counterfeit medications, and drug take-back programs on patient safety and access. The second area that we will review tonight is the standardization of pharmacy scope of practice and collaborative practice agreements. And the third area is reform of DEA enforcement related to the practice of pharmacy. While our time is limited, we want to receive your thoughts on the proposed policy statements and encourage you to submit your comments and questions during the webinar or send your thoughts to the House of Delegates. The webinar has been scheduled for 90 minutes, 15 minutes for intro and background information. Each topic has been allocated 20 minutes, and then 15 minutes has been reserved at the end for additional comments. For introductions, let's review the purpose of the APhA House of Delegates. The APhA Bylaws is the association's principal governance document. It outlines the purpose of the association, its membership, officers, and board, and the House of Delegates. The House of Delegates is the official policy development body for the association. The House debates issues of importance to pharmacy and sets policy for the profession. Since 1963, APhA has maintained association policy on a number of issues. The House may adopt new policy, refer a new topic to the Board of Trustees or another association group, reject proposed statements, or archive existing policy. These adopted policies guide APhA's advocacy activities on Capitol Hill and with federal regulators. They serve as the basis for APhA's response to media and public inquiries through our external communications and consumer outreach initiatives, and along with the association's strategic plan priorities, direct APhA's task forces and advisory committees as well as association activities. Much of the work of the House of Delegates is done by the committees. On your screen is a list of policy and other House-related committees that you might consider volunteering to serve on. The main committee we will be preparing for with this call is the Policy Committee. The APhA Policy Committee is charged with analyzing specific topics assigned by the Board of Trustees and proposing policy on those issues to the APhA House of Delegates. Policy Committee members generally meet in Washington, D.C. over a weekend within the months of September or October to develop policy statements. As mentioned earlier, for the 2011-2012 policy year, the committee will consider such policy topics as drug supply, scope of practice, and DEA regulation. The committee members must prepare a report of policy recommendations for presentation to the APhA House of Delegates. The committee is comprised of 7 to 10 APhA members from a variety of pharmacy specialties with specific professional and policy expertise. The other committees can be seen on this screen. If you would like more information on these committees and how to get involved with these committees, please go to www.pharmacist.com/HOD or submit an inquiry to hod@aphaMail.org. This information will be listed on slides at the end of the presentation. For additional background, the APhA bylaws also outline the composition of the House. The APhA House of Delegates is composed of approximately 400 delegate members representing various constituencies appearing on the screen. The APhA bylaws also outline the officers of the APhA House of Delegates. Pictured here is myself and Tom Menigan, who serves as Secretary of the House of Delegates by virtue of him being the Executive Vice President and CEO of APhA. Every other year, the House elects a Speaker-elect, who will assume the role of Speaker the following year. A solicitation call for candidates has been issued, and if you are interested in running for Speaker-elect, you can find the candidate application and other information at www.pharmacist.com/HOD. The House of Delegates office receives topic ideas from a number of folks, including delegates, members, state associations, committees, and trustees. This year, the House office received 29 topic ideas, which is twice the number we received last year. This may be attributed to the engagement of delegates following the 2011 House and the survey that was disseminated. Thank you to everyone for taking time to give feedback to improve the process. At the Academy's leadership meeting in May, the Joint Policy Standing Committee reviewed the background and potential direction of the topics. The committee prioritized and discussed the top 15 topics. Upon further discussion, the topics were combined based on their similarities, and then the top 4 topics were ranked. The committee then had additional discussion on the top 4 topics and answered the thought questions listed on the next slide in crafting their recommendation to the APhA Board of Trustees. The Joint Policy Standing Committee and the Board considered these questions in an effort to clarify and focus the topic areas. What is the problem? Why is it a problem? And in what direction should proposed policy take, and who should it be targeted to? The APhA Board of Trustees reviewed, discussed, and refined the 3 policy topic ideas seen on your screen. We will discuss these ideas more in depth during this webinar. The first topic to be discussed is the impact of drug supply shortages, counterfeit medications, and drug take-back programs on patient safety and access. There is no order of priority or preference to the proposed policy topic areas. This topic will focus on drug supply issues. Areas of consideration will include drug shortages, counterfeit medications, and other issues affecting the drug distribution supply chain that prevent patients from receiving the medicines vital to their health and well-being. Additionally, consideration will be given to systems being in place to ensure that unused medications are properly disposed of and do not fall in the wrong hands while meeting patients' needs. There are a lot of issues that could be wrapped within this topic, and the Policy Committee will attempt to address those areas that are most important issues and where gaps exist in current APhA policy. Issues posed to the board included production of raw materials and medicines in various parts of the world that support the global economy. Consumers in the United States are more reliant on other nations to contribute the medicines that make them well. What happens to the drug supply in America when a natural disaster in one part of the world or war erupts in another area? How will our patients receive the most appropriate medication, especially when no alternatives exist? Additionally, inpatient pharmacists are hit hard because they take care of very sick patients. However, this affects all areas of practice. Drug shortages also contribute to increased costs of available drugs. Also, prescribers will turn to pharmacists for information on available alternatives during drug shortages. Another component of being engaged in the global economy is the potential for the injection of counterfeit medications in the drug supply chain. Drug shortages are thought to increase the market for counterfeit drugs. Both drug shortages and counterfeit medications adversely affect the distribution supply and impact patient safety and patient access to effective medications. Suggestions received state that this policy should address ways manufacturers, the FDA, and pharmacists and pharmacies can work collaboratively to prevent, mitigate, and or resolve the drug shortages. For example, manufacturers could be required to report production problems that create shortages to the FDA. The FDA could issue public notifications in an effort to prepare prescribers and pharmacists, create a criteria for drugs vulnerable to shortage, and then recommend appropriate steps to pharmacies and pharmacists during shortages. There is not a lot of guidance in state and federal statutes or regulations in preventing or resolving shortages of critical medicines. The focus of this proposed policy could be to encourage federal officials to work closely with the public, pharmacists, manufacturers, healthcare professions to ensure a safe and adequate drug supply chain. Now is the time we would like to open up the call for discussion. If you have any questions, please raise your hand or use the chat features using the technology on the screen. Also, feel free to use the email to send a question to hod@aphanet.org.
Okay, Mr. Speaker, the lines are ready to accept questions or comments. If you have a question, please hit the raise hand icon and you'll be recognized. If you also want to submit it online, please do so in the chat or question area on your screen. Give a few minutes for somebody to type a question. Or again, if you want to verbally give your question or comment, please click on the raise hand icon and you will be recognized. As Speaker Tice had mentioned, are the areas that this proposed topic are proposed to address the right issues in your mind? We'd like to hear your thoughts. Okay, seeing no hands raised, Mr. Speaker, we can go on to the next topic. Just want to remind the participants that we will come back at the end of covering all three topics for questions on any of the three topics. So, Mr. Speaker, you're up next.
Thank you, Mitch. The second topic is the standardization of pharmacy scope of practice and collaborative practice agreements. This topic is related to standardizing scope of pharmacy practice and collaborative practice agreements between states. Should a pharmacist who is licensed in one state be able to provide MTM or cognitive services to patients who reside in another state? What about if a pharmacist has prescribing authority as part of a collaborative practice agreement in one state, but the patient lives or has the prescription filled in another state? Should pharmacists be able to provide MTM virtually, for example via video or teleconference, to patients inside and outside of their state? Does collaborative drug therapy management model language need to be standardized and or broadened? For example, should a CDTM be required to do MTM? The committee will consider what needs to be done to recognize and or reimburse pharmacists as providers on the healthcare team and how this impacts quality patient care. Some states allow pharmacists to prescribe, but scope of pharmacy practice is not consistent and lacks standardized definitions between states. This contributes to inconsistent advocacy activities at the state and national levels. Various versions of scope of practice make it very difficult for pharmacists to practice pharmacy in multiple states. Policy may be considered around issues of state licensure and allowing pharmacists to practice at the top of their license to improve quality and lower costs. Having consistent scope of pharmacy practice between states is a topic to consider whether or not it will help ensure that patients and their healthcare providers recognize the value of pharmacists. Further areas of consideration include how limitations in practice acts can contribute to the lack of business models for pharmacist-provided patient care services and is contrary or may be contrary to the practice at the top of your license philosophy. Other consideration will be how this leads to frustration by student pharmacists and dissatisfaction of pharmacists for skills and abilities not being used. The policy committee will look at these areas and consider them within existing policy to address these issues. Additional consideration will be given to if and how APhA should support a universal scope of practice and uniform state laws that recognize pharmacist-prescribed prescription orders and the provision of consulting services by pharmacists no matter which state the pharmacist is licensed or no matter the state which the patient resides. Now is the time we would like to open up the call for the discussion on the second topic area. If you have any questions, again, please raise your hand or use the chat features using the technology on the screen. Or again, feel free to email a question to hod@aphanet.org.
Okay, Mr. Speaker, we do have a question. The question is, will the policy address the value of a federal or national pharmacist license to overcome the short-sightedness of state laws or boards?
That is certainly a part of the discussion that has occurred already, and we will be certain to include those comments for the policy committee's consideration. Thank you.
Okay, we've got a request to go back one slide for a little bit longer so people could spend some time looking at that a little longer.
And we should add, we certainly recognize that we are introducing these topics to you for the first time, and we would really look forward if you, once you are able to absorb them, that you could email further comments for the policy committee to consider between now and the time that the policy committee meets in the middle of October.
And these slides will be on the website. The presentation will be archived in about a week after this presentation. Okay, we've got a comment. I think this policy is very important because some of us live in states where we are prohibited from providing MTM services unless we are in a physician or unless we are in a physical pharmacy.
Thank you. And if you could provide an example of which specific state that is, we could make sure we looked at the regulations and practice acts.
Another comment is, can it break into two oversight? one for federal core scope, and leave others to the states. Another comment or question is, I do not understand the phrase practice at the top of your license. Could that be explained?
Yes, what is meant by that is where in one state there could be the ability to prescribe or at certain levels or after certain certifications, and the ability for that level of practice to be maintained across other states.
Okay. I want to remind folks that if you want to actually verbally give your comment or question, just click on the raise hand icon and we'll click your line open so you could speak. Feedback on the state, Mr. Speaker, that you asked earlier is from the state of Alabama. Another comment is, was there any discussion regarding seeking independent provider status for pharmacists versus emphasis on team-based care, i.e. medical home model?
There has been much discussion around that topic area, and that is definitely one of the most discussed areas within this topic area. So we'll definitely receive consideration.
And to add to that, Mr. Speaker, is both the advisory committee as well as the board talked about the scope of practice, collaborative practice within a reformed healthcare system. So that question's a very good one that the committee will be focusing its look at. Question is, would this facilitate precepting across state lines?
Yes, certainly.
I'd like to hear a little more about on the precepting one. For folks who do precept individuals from out of state, are you facing any barriers in relations to state laws that we need to take into consideration when we're looking at these policies? A suggestion has come across: can we use the term compensation versus reimbursement? And that's a good point that we will look at in the final language and reports to make sure there's this distinction between those two, where compensation is typically tied to the provision of a service versus a product. Okay, let's keep on moving here. Here's another point. Are we going to get to the point where we are overly credentialized, thereby making our current PharmD degree inadequate and limiting the number of pharmacists who are capable to deliver MTM services?
That will certainly be a part of the discussion that's been brought up as well, and the whole topic area around provider status. Part of the question that has to be answered there is if or what other credentials, if any, are required or necessary.
Another question that has come in is, would this facilitate distribution of the labor force throughout the country?
I can see how that would come up, and it certainly would seem as a possible way to impact that. And we can make sure that that's discussed as part of the committee as well.
Okay, and in response to our question that we asked earlier about challenges that folks are having in precepting students, one participant says that, yes, Missouri and Illinois do not allow pharmacy students to do the same functions. And another individual has says there is a variation in intern licenses between the states and the Northeast. Another point that, okay, another question or point that it just came in. One issue that comes up is, do you need a collaborative practice agreement to practice MTM? It certainly makes it easier to implement changes that way, but they don't necessarily go hand in hand. Please note this when finding a title for this policy, since both are included.
Thank you.
Again, if you want to give a verbal comment or question, please click on the raise hand icon and we'll open your line. Okay, see no hands raised, no other comments coming in. Mr. Speaker, go to the third topic.
Thank you, Mitch. The third topic area is examination of DEA regulation activities and its impact on patient care and access to medications. This issue relates to an examination of DEA activities related to the enforcement of pharmacy practice. Specifically, there is increased interest to update the Controlled Substance Act to better reflect contemporary practice. Pharmacists who are able to receive electronic prescriptions and use electronic medical records in the community setting have expressed the desire to have the ability to receive prescriptions for controlled medications. Additionally, DEA enforcement activities have not recently been reported to be consistent with state practice acts. The Controlled Substance Act has not undergone any significant updates in its 35 years in existence. The DEA enforces the Controlled Substance Act with narrow interpretations in comparison to the flexible interpretation of the Food, Drug, and Cosmetic Act by the FDA. Paperless record systems, compliance packaging, cycle filling, new models, and changes to scope of practice for healthcare professionals are areas that need to be reviewed for update of the Controlled Substance Act. Additionally, charges are being filed against pharmacies that are in compliance with state laws but are found to be in violation of the Controlled Substance Act. The challenge is the DEA is enforcing the Controlled Substance Act with novel policies that are not aligned with the environment. Claims for controlled substances are under intense scrutiny and are being rejected by pharmacy auditors due to the DEA's narrow interpretation. It is felt by some that the DEA's inability to effectively respond to changing circumstances contributes to waste, unavailability of controlled substances in households due to growing rates of prescription abuse, drug abuse by Americans, particularly teenagers, and high drug costs because of the DEA's prohibition of cost-efficient drug distribution systems. There are many examples that we will review of current problematic interpretations that have been provided. Some of these include asserting that prescriptions without the issuing prescriber's DEA number are invalid. Pharmacists are restricted from adding the DEA number after the prescription is issued. This presents a barrier to patient access to medications. Asserting that nursing home pharmacies who accept returns of unused unit dose and modified dose medications for the purpose of providing credit to payers, including Medicaid, can be charged. Other areas of recent problematic interpretations by the FDA include asserting that nurses are prohibited from faxing copies of written or verbal chart orders for Schedule 3 or 4 drugs to the pharmacy unless the prescriber has an agreement with each nurse, presenting a barrier to nurses providing patient care. Asserting that pharmacists are prohibited from acting as an agent of the prescriber when issuing detailed prescription refill requests for Schedule 3 or 4 drugs that provides a signature line for prescriber to sign and return by fax an authorization, presenting a barrier to pharmacists providing patient care. Additionally, asserting that a pharmacy which prepares compliance packages or blister cards of controlled substances for use by a jail must register as a repackager if packages are not labeled for an individual patient. Asserting that a pharmacy may package a 1-month supply of Schedule II drugs into 4 separate 1-week bottles and dispense the bottles one at a time in accordance with prescriber's request for help with patient adherence. And additional areas, including asserting that a pharmacy may not receive a patient's controlled substances and repackage them into compliance packaging as part of a nursing home modified unit dose dispensing system or for a patient in an assisted living facility. And asserting that a pharmacy receives faxes for Schedule III or IV drugs must print a hard copy for its files, despite approval by state boards of pharmacy for the use of a paperless record system. As you can see, there have been many areas of concern communicated in this topic area. Now is the time we would like to open up the call for discussion for the third topic area. If you have any questions, again, follow the previously used procedures. If you would like to go back to any of those slides, feel free to request that. We know there is a lot of examples provided and a lot of areas for discussion in this topic area.
Okay, we're ready to receive comments or questions. If you have a question that you want to deliver verbally, please click on the raise hand icon and your line will be open. A couple of comments have come in online. As the scope of practice arena is always in flux, is there really a point of having too many credential items? I think that was for the previous one. Sorry about that. We'll come back to that one. Will an adjustment be made to move medical marijuana from a Schedule I status to allow for the legal dispensing of medical marijuana on a state-by-state basis?
Well, actually, that was one of the topic areas reviewed by the committees and by the Board of Trustees, and you will see it was actually referred from last year's House, and we actually chose not to use that as a topic area this year for several reasons. One of the primary ones being, or two of the primary reasons being that there's currently already association policy, actually 3 reasons. There is also a treaty involved that would have to be changed in order for that to be accomplished. And the third reason is that we chose to have some print publications and take action outside of existing policy because we felt existing policy covered that area. And at next week's Board of Trustees meeting, when we meet with the state executives from across the country, we are going to be specifically addressing this issue and discussing it to learn more about what is happening in the states, what needs to be addressed, and how we can identify areas to address what's going on with medical marijuana. Certainly, if you have more examples, that if you can submit those to the APhA email that we provided, hod@aphanet.org, any information we can have to build our case and reinforce and understand what's going on will be useful.
And we will also be meeting at that time also with DEA representatives. A comment that came in, this reform is long overdue.
We've gotten that sense.
I've got a hand raised. Steve Furman, your line is open.
I didn't know that my line was open, but that's great. I just wondered if we could go back one slide. Thank you.
Okay, thank you, Steve. Okay, another comment that came in. Is there a concern of conflict of interest by certain agencies, i.e. reduced costs to government programs through intense regulation?
I'm sure there is a concern, and I'm sure it's something that we can discuss as we're developing policy.
Just for clarification on that comment, is it a reduced cost by, in perspective of the DEA, or a way of increasing some revenue through fines? Can you elaborate a little more, or just thinking on that? Again, if you want to give verbal comments, just click on the raised hand icon and we'll open your line. Okay. While we're waiting for feedback on that one, another comment came in. I'm glad the association is looking into a policy on this topic. APhA ASP passed a policy a year or two ago recommending that the DEA update the Controlled Substance Act to allow for e-prescribing of C2 prescriptions. The comment that came in earlier is it's just a thought on reducing expenditures via claims. That would reduce some of that potential. Another comment, the DEA take-back program for disposition of unused controlled medications are just starting out and do not include pharmacies. I would like to see more collaboration. Mr. Speaker, I can actually elaborate on that one. In a meeting that the Joint Commission on Pharmacy Practitioner Organizations had with the DEA about 2 weeks ago, we talked about different issues, and one of them was the take-back program. And the position of the DEA is that pharmacies and their organizations are considered under the Department of Justice process as regulated entities, and that the DEA has to keep, in their mind, a arm's length distance from regulated entities. So in terms of collaborating directly with practitioners, that's not in their policies and procedures. But other government agencies they can collaborate with, and they are collaborating with the National Associations of Boards of Pharmacy, FDA, and some other state agencies. For a pharmacy to get more involved in that, we need to work with some of those other agencies that don't have that same interpretation, and that's a roundabout way of pharmacy getting more involved in those entities, and that's what we're going to be working on from all the pharmacy organizations of how to get pharmacy more involved and integrated into those programs. It won't be directly with the DEA, but the other agencies that they're working with. Okay, I see. Steve Furman, your hand was raised.
Yes, I wondered if you're thinking when we talk about supporting advocacy and pressing for administrative and legislative reforms, do you think the committee is going to try to spell out the sorts of reforms that we want, or just call for those reforms to happen?
Yeah, I'm sure that'll be a part of the deliberations. I don't know if that's really been determined yet, but it certainly would be a part of the discussion.
Okay, other comments or questions? Click on your raised hand icon and we'll open your line. Or if you'd like to type your comment, do that and we'll read it out loud. Okay, another question. is will you be writing up the DEA take-back program you just discussed with us so we can read it? Yeah, we've written about it before, but this update hasn't been put together yet since it just happened, and so as we get more info and figure out strategies, something will be put in probably into one of the publications. Other questions or comments? We've had some good comments and questions. Are we on the right topics in relation to the DEA issues? Have we hit all the ones, or are there some other ones that the committee should look at? All right, Mr. Speaker, I don't see anybody submitting any questions or raising their hand.
All right, let's go ahead and move to the next slide and open it up for discussion on any of the three topics.
Okay, we've got one going back to the drug shortage issue. Question is, will this policy address people trying to take financial advantage of a shortage?
I think that's a good thought for consideration. It will definitely be included as a part of the discussion.
Okay, here's another comment. Have we considered any unforeseen ramifications of warning about shortages, i.e. hoarding or stockpiling?
I think that's another good point to bring up. And I would just like to reinforce the stage we're at in the process is that we've really been focused on generating the topic ideas, that your comments here and the comments that you present between now and the middle of October can really help us to identify the areas that need to be addressed and that we need to be considered as we develop those topic statements. So these will definitely be included and shared with the committee.
And to follow up on that question, what would you like to see? What are the wish I had related to the shortage situations that you face in your practice every day? What is it that we should be asking for in this area? While you think about that and put together your thoughts, or don't forget, you can click on the raise hand icon. We've got another comment that came in while you're putting together your thoughts. Or will we see an increase in overall cost and thus drive more manufacturers out of the market for some items? One suggestion that just came in, I would also like to see someone from the PHS consulted about the shelf life extension program to add input to the shortage topic.
Thank you.
For the person who put that one in, could you explain a little more of how you see the shelf life extension program addressing the shortage? Is it because the short expiration dating that's causing the shortage, or how do you see that helping? While people are thinking about that one question, we've got a comment that just came in related to the controlled substance. I have heard pharmacists say that they're concerned that the number of pharmacy robberies will increase if hydrocodone is moved to Schedule 2. I am not familiar with all of APHA's policy and not sure how this concern about pharmacy crime is currently addressed. Well, APhA policy book has in it for a number of years supporting the federal crime for pharmacy robberies. So we've been on record for a long time in support of that. Good concern, though, in terms of moving anything to a Schedule II. What impact will that have? And something that the committee will look at as part of its work. Again, if you want to give your comments verbally, please click on the raise hand icon. It may be easier than having to type it in. Another comment that just came in, a related item to look at in terms of increased crime is the recent topic of pharmacists legally carrying guns. Any thoughts?
I think that's definitely a state-by-state consideration based upon the carry laws. It's definitely something we can talk about. I'm pretty sure we do not have policy on the books today in that area.
And that's one topic that's not, I don't think that this would be encompassed under the area that the committee will be talking about in this policy, and that could be something that somebody may want to consider as a new business item or for further discussion, consideration in next year's House. Other comments or questions, click on the raised hand icon, or you can type your comment in and we'll read it to the group. We'll wait a few more minutes. Okay. Ellen, your line is open. Go ahead.
Sorry, I've been pressing it mistakenly, so sorry about that.
Okay, no problem. Good talking to you. Okay, here's a comment. Could drug shortage policy address federal pharmacy and how the Trade Act agreement impacts procurement during times of shortage?
I think we could definitely develop policy. We have to determine what actions we would take then to implement that policy and to take action on that policy as well.
I think you bring up a good observation that we'll look at further. Okay, in terms of the shelf life extension, I have seen issues with shortages that are extended over many months, and we could use drugs past the expiration that we would normally have returned. It is hard to send back a drug due to expiration when you know you will not get a replacement. Good observation, and we will definitely have the committee looking at that perspective. Okay, Andrew, your line's open.
For policy number 2, I was just wondering if there was any talk or if the committee would take into consideration working with NABP to update some of the exams, either the MPJE or the NAPLEX or both, to more reflect current pharmacy practice, probably more the MPJE. And if you need an example, I can help with that, but just wanted to get that comment in.
Sure, yeah. The specific examples are definitely helpful.
Well, I just had an example where I recently licensed here in the state of Missouri, and everything on the exam that was in there is nothing that I'm doing currently, since I practice, more the clinic-based pharmacy, and a lot of it was just very dispensing-based driven, which is kind of what most MPJEs are. And so where that would be reflected in practice, I'm not sure, as we look at advancing scope of practices.
Yeah, I can't remember offhand, Andrew, when the last blueprint analysis. I think they just completed one, so it may have not be showing up in the exam yet. But that's what the exams are based on, is they do a review of practice and look at the domains to update the exam. So I'll have to look more into it when the last one was done. Maybe somebody on the line knows when that last one was done.
Okay, just for the committee consideration.
Okay, thanks for the input. Okay, here's a comment related to the shelf life extension program. There's a team at FDA drug shortage program who can work with manufacturers to extend the shelf life once the firm submits studies to show the stability of the product.
Yeah, I thought that's what you might be referring to. And if you have expertise in this area or know of people that can submit background information, that would be extremely helpful. And we're about to say this at the end as well. But if you or yourself have expertise in any of these three areas, or if you know of anyone else that you think would be a great person to be a resource and provide expertise in these areas that can help really develop solid policy in these areas, encourage them to nominate yourself or the other person, or get them to nominate themselves if as appropriate, and we'll provide that information on the next slide.
Okay. A couple of comments that are coming in. There's a public meeting at FDA that will address drug shortages. They'll be sending out a transcript from the meetings. I will include people from the industry, patient. It will include people from the industry, patients, and FDA folks, as well as the as Congress has done some hearings on the issue. So it's one that's being looked at from many facets. So we'll hopefully have some good inputs from those activities. FYI, the shortage issue is causing entrepreneurs to buy in one country to sell elsewhere. As a result, foreign countries are now trying to restrict meds in their countries to protect their patient population. One suggestion too is Tennessee has been leading the injectable drug shortage area, and a resource would be to talk to Bettina Black.
Thank you.
Okay, other comments, questions? Again, click on the raised hand icon or type your comment in and we'll read it out to the group. Okay, Mr. Speaker, I don't see anybody raising their hand, or, oh, I got Steve Furman. Hold on. Steve, you're live.
Thank you. I just wanted to say to you, Speaker Tice and Mitch, thank you very much for doing this. I think this has been real useful, and I hope that others will continue to provide comments to the Policy Committee. I think that's the best way that they can do their work.
Thank you, Steve.
Thank you, Steve. And the other person who's behind the scenes putting this stuff together is Brian Lawson on the APhA staff. Okay, here's a comment. I've experienced shortages due to available brand names being incompatible with automation. I'd like to learn a little more about that one in terms of how automation has created shortages. If somebody wouldn't mind, probably if you could click the raise hand icon so you can give verbally, it'd be easier. Okay, while we're waiting to see if we get a response on that one, just want to remind some folks have been also submitting some ideas for other policy topics, and I want to encourage folks, if you have an idea, while the committee may not be one of the 3 topics the committee is addressing, you can still propose policy through the new business process for the House. So if you've got an idea that you want to get before the House, as a delegate, you have the right to submit a proposed policy through the new business submission process.
Yes, that was really one of the motivations for getting the topic areas out early, to provide more time if people saw areas that were not being addressed, that they were able to have more time to develop them and think about them and get more support around them going into the House in the spring. So that would be great.
One comment is, in our mail-out setting, some automation requires recalibration by the equipment manufacturer. So I assume then that makes those products not available for dispensing until that's fixed. Or I guess it's going back to the old way of the counting tray. Okay, we'll just take one more run through. Anybody have any verbal comments? Please click on the raise hand icon or submit your comments via the computer. Last call. Okay, Mr. Speaker, I don't see anybody with their hand raised or any comments coming in besides thank you through the computer.
All right, as we close this webinar, we want to highlight some upcoming events. The Policy Committee will review feedback from tonight's webinar and use this information as it develops proposed policy statements. The committee will meet in Washington, D.C. October 14th to the 16th. We are still soliciting names for people interested in serving on the Policy Committee. If you have expertise and experience to help shape proposed policy, please go to www.pharmacist.com/HOD and click on the Call for House Committee Volunteer link. You may also submit your CV or resume via email to hod@aphanet.org. A webinar to review the proposed policy statements developed by the Policy Committee will be available prior to the annual meeting in an effort to educate members on the statements. The Policy Reference Committee will receive and consider comments during its open hearing at the 2012 APhA annual meeting. As we mentioned, if there is a topic you feel needs timely consideration by the 2012 APhA House of Delegates, please submit to the House of Delegates as a new business item. New business forms are available on the House of Delegates website. This concludes our webinar. We appreciate your time, attention, and participation tonight. Thank you for your interest in the policy development process. If you have additional questions or comments, please drop us a line or an email at hod@aphanet.org. Thank you and good night.